7. Care of patients with conditions of the central nervous system, the spinal cord. The spinal cord relies messages to and from the brain. Besides injuries, the spinal cord can develop inflammatory and autoimmune disease such as multiple sclerosis, MS, and tumors, both benign and malignant. The spinal cord itself may be damaged, or the spinal nerves leading from the cord to the extremities may be affected. In some cases, both the spinal cord and the nerves are involved. Adult spinal health conditions may be acute or chronic and often can be managed in the community. End-of-life care is not needed unless the patient has a large inoperable cancerous spinal cord tumor or spinal metastatic disease. Signs and symptoms of spinal cord health conditions vary, but often include problems with immunity, mobility, sensory perception, cognition, and sexuality. Interprofessional healthcare team members with expertise in symptom management collaborate to improve quality of life, promote a safe environment, and prevent complications from spinal cord health conditions. Our first exemplar is about multiple sclerosis. Multiple sclerosis is characterized by periods of remission and exacerbation, also known as a flare. Patients progress at different rates and over different lengths of time. However, as the severity and duration of the disease progresses, the periods of exacerbation become more frequent. Patients with MS can have a normal life expectancy as long as the effects of the disease are managed effectively. As described in Chapter 35, myelin is responsible for the electrochemical transmission of impulses between the brain and the spinal cord and the rest of the body. Demyelinization can result in slowed or stopped impulse transmission. MS is characterized by demyelinization or loss of myelin sheaths. Diffuse, random, or patchy areas of plaque in the white matter of the central nervous system are the definitive finding. Initially, remyelination takes place to some degree, and clinical symptoms decrease. However, over time, new lesions develop and neuronal injury and muscle atrophy occur. The areas particularly affected include optic nerves, spinal pyramidal tracts, spinal posterior columns, brainstem nuclei, and the ventricle region of the brain. The four major types of MS include clinically isolated syndrome, relapsing remitting, primary progressive, and secondary progressive. Clinical isolated syndrome, or CIS, is an episode of neurologic symptoms, often attributed to MS, that lasts for at least 24 hours. An MRI may or may not show evidence of MS, so a diagnosis is not yet possible. A little over half of the patients diagnosed with CIS develop MS within 10 years, and disease-modifying therapies are often started to prevent or delay the onset. Radiologically isolated syndrome, or RIS, is often diagnosed incidentally in a person having an MRI for another problem, such as headaches or head trauma. It is characterized by isolated lesions that are similar to those of MS in a person who does not have a current or past history of symptoms of the disease. Relapsing remitting multiple sclerosis, or RRMS, occurs in most cases of MS. The course of the disease may be mild or moderate depending on the degree of disability. Symptoms develop and resolve in a few weeks to months, and the patient returns to baseline. During the relapsing phase, the patient reports loss of function and the continuing development of new symptoms. The majority of patients are diagnosed with this type initially. Primary progressive multiple sclerosis, or PPMS, involves a steady and gradual neurologic deterioration without remission of symptoms. The patient has progressive disability with no acute attacks. Patients with this type of MS tend to be between 40 and 60 years of age at onset of the disease. Secondary progressive MS, or SPMS, begins with a relapsing remitting course that later becomes steadily progressive. Many people with RRMS develop SPMS within 10 years. The current addition of disease-modifying drugs as part of disease management may decrease the development of SPMS. Progressive relapsing multiple sclerosis, or PRMS, is an older label for the uncommon type of MS characterized by frequent relapses that partially recover but not to return to the baseline. This type of MS is seen in only a small percentage of patients. Progressive, cumulative symptoms and deterioration occur over several years. The cause of MS is very complex and involves multiple immune, genetic, and/or infectious factors, although changes in immunity are most likely the etiology. The environment may also contribute to its development. For example, the disease is seen more often in the colder climates of the Northeast, Great Lakes, and Pacific Northwest states, and in Canada. MS usually occurs in people between the ages of 20 and 50 years old, but cases may occur at any age. Nearly 1 million people in the United States have MS. The disease affects over 2.3 million people worldwide. About 90,000 Canadians also have MS. MS affects women 2 to 3 times more often than men, suggesting a possible hormonal role in disease development. Some studies show that the disease occurs up to 4 times more often in women than men. However, the exact reason for this difference is not known. Multiple sclerosis often presents like other neurologic diseases such as ALS or amyotrophic lateral sclerosis, which can make the diagnosis difficult and prolonged. ALS is also a progressive neurogenic disease that affects neurons in the brain and the spinal cord that is likely caused by genetic mutations. Unlike MS, there is no established treatment or cure for ALS, which is 100% fatal. Recently, a combination drug of sodium phenylbutyrate and taurursodiol has been approved to slow physical function decline for patients with ALS. Patients often visit primary care providers and undergo a variety of diagnostic tests and treatments to obtain the correct diagnosis. Obtaining a thorough history is essential for accurate diagnosis. Ask the patient for a history of vision, mobility, and sensory perception changes, all of which are early indicators of MS. Symptoms are often vague and nonspecific in the early stages of the disease and may disappear for months or years before returning. Many patients have a single isolated clinical episode that lasts for 24 hours or more. These neurologic symptoms then disappear and occur later. Ask about the progression of symptoms. Pay particular attention to whether they are intermittent or are becoming progressively worse. Document the date, month, and year when the patient first noticed these changes. Next, ask the factors that aggravate the symptoms, such as fatigue, stress, overexertion, temperature extremes, or a hot shower or bath. Ask the patient and the family about any personality or behavior changes that have occurred, such as euphoria, very elated mood, poor judgment, or attention loss. In addition, determine whether this is a family history of MS or an autoimmune disease. MS produces a wide variety of signs and symptoms, therefore each patient may present differently. Some patients with relapsing or remitting MS also report pain. It's important to perform a complete pain assessment as described in Chapter 6 for all patients with MS. Psychosocial assessment. A major concern reported by most patients is how long it takes to establish a diagnosis for MS. Many patients go to several primary care providers and are given varying diagnoses and treatments, and are told that their symptoms are related to stress and anxiety. Often young adults present with weakness, fatigue, or changes in vision and are diagnosed with exhaustion and advised to get more sleep. The patient and family are relieved to have a definitive diagnosis, but may express anger and/or frustration that it took too long to start appropriate treatment. Therefore, establish open and honest communication with the patient and allow them to share frustrations, anger, and anxiety. After the initial diagnosis of MS, the patient is often anxious. Apathy and emotional lability are common problems that occur later. Depression may occur at the time of diagnosis and can also occur later with disease progression. The patient may be euphoric either as a result of the disease itself or because of the drug used to treat it. We have to assess the patient's previously used coping and stress management skills in preparing for the chronic, potentially debilitating disease. Secondary depression is the most frequent mental health disorder diagnosed in patients with MS. Assess the patient for mental status changes. Changes in cognition are usually seen late in the course of the disease, and it can include decreases in short-term memory, concentration, and the ability to perform calculations, inattentiveness, and impaired judgment. Assess the impact on bowel and bladder problems. Managing urinary or fecal incontinence or constipation can be time-consuming and embarrassing. Common symptoms and conditions would include muscle weakness and spasticity, fatigue, usually with continuous sensitivity to temperature, flexor muscle spasms, numbness or tingling sensation or paresthesia, Visual changes such as diplopia, nystagmus, or involuntary eye movements, decreased visual acuity, or changes in peripheral vision. Bowel and bladder dysfunction, either flaccid or spastic. Alterations in sexual function, such as erectile dysfunction. Cognitive changes such as memory loss, impaired judgment, and decreased ability to solve problems or perform calculations. Depression. Dysesthesia, or an MS hug, squeezing sensations around the torso, often one of the first symptoms of the disease or a relapse. Difficulty walking, including dysmetria, which is the inability to direct or limit movement, and ataxia. Vertigo, dizziness. Pain and itching, emotional changes. Some less common symptoms and conditions would be an inattention tremor, which is tremor when performing an activity. Hypoalgesia, which is decreased sensitivity to pain. Dysarthria, or difficulty speaking due to slurred speech. Dysphagia, difficulty swallowing. Decreased hearing acuity. Tinnitus, or ringing in the ears. Loss of taste, and seizures. Sexuality can be affected in people with MS, and sexual dysfunction can have a major impact on quality of life. It's important to assess the patient's fatigue level and patterns, since fatigue contributes to sexual dysfunction. Be sensitive when asking about the patient's sexual practices and orientation. Women often report impaired genital sensation, diminished orgasm, and loss of sexual interest. Men most often report difficulty in achieving and maintaining an erection and delayed ejaculation. Laboratory assessment. No single specific laboratory test is definitively diagnosed for MS. However, the collective results of a variety of tests are usually conclusive. Abnormal cerebrospinal fluid, or CFF, findings include elevated proteins, or oligoclonal bands, and an increase in the white blood cell count. CSF electrophoresis reveals an increase in the myelin basic protein and the presence of increased immunoglobulins, especially immunoglobulin G. Newer tests are being developed to identify biomarkers for MS. Other diagnostic assessments. An MRI of the brain and spinal cord that demonstrates the presence of plaques in at least 2 areas is considered diagnostic for MS. MRIs with contrast may show active plaques and reveal older lesions not associated with current symptoms. Evoked potential testing, usually the visual evoked response, may be performed for patients suspected of having MS. This non-invasive test can identify impaired transmission along the optic nerve pathway. Impaired immunity due to the disease and drug therapy for disease management is a problem. Decreased or impaired mobility due to muscle spasticity, intention tremors, and/or fatigue is a problem. And decreased visual acuity and cognition due to dysfunctional brain neurons develops. When making a plan for an MS patient, we're having these expected outcomes. The patient with MS is expected to be free from episodes of secondary infection due to impaired immunity from the disease or from drug therapy used to manage the illness. Interventions. As with any chronic disease, clients who have been diagnosed with MS are at an increased risk for infection. We want to teach these patients to avoid large crowds, and anyone who is sick, remind them to wash their hands frequently and use hand sanitizer when soap and water are not readily available. For drug therapy, the patient with MS is treated with a variety of drugs to treat and control disease progression. Medications can be administered orally, by injection, or by infusion. Many of these drugs are immunomodulators, or anti-inflammatory medications that can alter immunity and place patients at risk for secondary infection. We need to teach patients receiving drug therapy for MS to avoid crowds and anyone with an infection. If signs or symptoms of infection occur, remind them to contact their primary care provider with prompt management and medical observation. Other medications are used to control symptoms such as bladder or bowel dysfunction, fatigue, itching, pain, sexual problems, spasticity, tremors, or gait disturbances. Examples of drugs used for treatment for relapsing types of MS include interferon B preparations, immunomodulators that modify the course of the disease and also have antiviral effects. Medications such as methotrexate, an IV anti-neoplastic anti-inflammatory agent, are used to resolve relapses, but with risks for leukemia and cardiotoxicity. Medications like natalizumab, the first IV monoclonal antibody approved for MS that binds to the white blood cells to prevent further damage to the myelin. Patients have to be monitored very closely for allergic or anaphylactic reaction with this medication when each dose is given because the drug tends to build up in the body. Patients receiving this drug are at risk for progressive multifocal leukoencephalopathy or PMO. This opportunistic viral infection of the brain leads to death or severe disability. We have to monitor for neurologic changes, especially changes in the mental state, such as disorientation or acute confusion. PML is confirmed by MRI and by examining the cerebral spinal fluid for the causative pathogen. Nacalzibab can also damage the hepatic cells, so careful monitoring the liver enzymes and teaching patients to have frequent laboratory tests to assess for changes. Methotrexate, a chemotherapy drug, has been shown to be effective in reducing neurologic disability. It also decreases the frequency of clinical relapses in patients with secondary progressive relapsing, or worsening relapsing remitting MS. Fingolimab also was one of the first oral immunomodulators approved for the management of MS. The capsule can be taken with or without food. We have to teach patients to monitor their pulse every day because the drug can cause bradycardia, especially within the first 6 hours of taking it. Several other immunomodulating drugs have been approved for MS, like fingolimab. These drugs inhibit immune cells and have antioxidant properties that protect the brain and spinal cord cells. We want to teach the patient that the two most common side effects of the oral drug are facial flushing and GI disturbances. Remind the patient to keep follow-up appointments for laboratory monitoring of the white blood cell count because the oral drugs can cause a decrease in white blood cells, which can predispose the patient to infection. The interferons and the subcutaneous injections are medications that the patient can self-administer, so it's important to teach the patient how to give and to rotate the site of injections because local injection site skin reactions are common. The first dose of these drugs is given under medical supervision to monitor for allergic reactions, including anaphylactic shock. We want to teach the patient receiving them to avoid crowds and people with infections because these drugs can cause bone marrow suppression. We want to remind them to report any signs or symptoms associated with infection immediately to their primary care provider. Instruct patients about flu-like reactions that are very common for patients receiving any of the interferons. These symptoms can be minimized by starting at a low-dose drug and giving acetaminophen or ibuprofen. Adverse effects of the glatiramer are not common. Another treatment for multiple sclerosis is medical marijuana. The National Multiple Sclerosis Society supports the use of medical marijuana or cannabis for symptom management. Studies have shown that cannabis can reduce neuropathic pain, muscle stiffness, and spasticity for patients with MS. Consistent availability of quality of cannabis in a legalized use state gives patients more options about the type of products that may be effective. Another treatment option is stem cell therapy. It's being researched as a promising treatment to manage MS. Stem cells may be derived from adult or embryonic tissue, although embryonic stem cells are preferred because they are often more effective. The therapy may slow the progression of the disease and decrease the symptoms, but does come with its own legal and ethical considerations. The symptoms of MS can affect mobility, including spasticity, tremor, pain, and fatigue. Referral to rehabilitative services such as physical and occupational therapy can help manage functional deficits from MS symptoms. An interprofessional team approach is important to attain patient-centered outcomes for care. To lessen muscle spasticity, which can often contribute to pain, the primary healthcare provider may prescribe baclofen or tizanidine. Severe muscle spasticity may also be treated with intrathecal baclofen, administered through a surgically implanted pump. Peristalgia may be treated with carbamazepine or tricyclic antidepressants. Propranolol hydrochloride and clonazepam have been used to treat cerebellar ataxia. In collaboration with physical and occupational therapists, plan an exercise program that includes range of motion exercises and stretching and strengthening exercises to manage spasticity and tremors. If needed as a last resort, neurosurgery can implant a deep brain stimulator, which may provide some relief from tremors. We want to emphasize the importance of avoiding rigorous activities that increase body temperature. Increased body temperature may lead to increased fatigue, diminished motor ability, and decreased visual acuity resulting from changes in the conduction ability of the injured axons. In collaboration with the case manager and occupational therapist, we have to assess the patient's home before discharging for any hazards. Any items that might interfere with mobility, such as scatter rugs, are to be removed. In addition, care must be taken to prevent injury resulting from vision problems. We want to teach the patient and family to keep the home environment as structured and free from clutter as possible. As the disease progresses, the home may need to be adapted for wheelchair accessibility. Adaptations in the kitchen, bedroom, and bathroom may also be needed to promote self-management. Any necessary assisted adaptive device should be readily available before discharge from the hospital. The patient with MS is often weak and easily fatigued. Teach the patient the importance of planning activities and allowing sufficient time to complete these activities. For example, patients should check that all items needed for work are gathered before leaving the house. Items used on a daily basis should be easily accessible. A recent study showed beneficial effects of brief mindfulness training for hospitalized patients to manage their fatigue. If the patient experiences dysarthria as a result of muscle weakness, refer the patient to the speech-language pathologist for evaluation and treatment. It is not unusual for the patient with dysarthria also to have dysphagia. The speech-language pathologist performs a swallow evaluation, but further diagnostic testing may be indicated. Monitor the patient to determine whether the problems of swallowing at mealtime that increase the risk of aspiration. In some cases, thickened liquids may be necessary. When we're managing decreased visual acuity and cognition, our plan is that the patient with MS is expected to maintain optimal visual acuity and cognition with use of available drug treatment and supportive services. Interventions or alterations in visual acuity and cognition can occur at the time during the course of the disease process. Areas affected include attention, memory, problem solving, auditory reasoning, handling, distractions, and visual perception. An eye patch is alternated from eye to eye every few hours, usually relieving the double vision. For peripheral visual deficits, teaching scanning techniques by having the patient move their head from side to side. Changes in visual acuity may be helped by corrective lenses. For complementary and integrative health, patients with MS often report that complementary therapies are successful in decreasing their symptoms and managing anxiety and/or depression. Some of the integrative therapies used to treat patients with MS are reflexology, massage, yoga, relaxation and meditation, acupuncture, and aromatherapy. Patients with MS usually are able to live independently with their disease, but some may need assistance. To help the patient maintain maximum strength, function, and independence, continuity of care by an interprofessional team in the rehabilitation and/or home setting may be needed. In severe disease, placement in an assisted living or long-term care facility may be the best alternative. The population of young and middle-aged residents in the settings is increasing as people with physical disabilities are living longer. The primary healthcare provider explains to the patient and family the development of MS and the factors that may exacerbate the symptoms. Emphasize the importance of avoiding overexertion, stress, extreme temperatures, humidity, and people with infections. Explain all medications to be taken on discharge, including the time and route of administration, dosing, purpose, and side effects. Teach the patient how to differentiate expected side effects from adverse or allergic reactions, and provide the name of the resource person to call if questions or problems occur. Provide written instructions as a resource for the patient and caregivers at home. The physical therapist develops an exercise program appropriate for the patient's tolerance level at home. The patient is instructed in techniques for self-care, daily livings, and positioning techniques. Teach patients about conversation strategies that balance periods of rest and activity, including regular social interactions. Remind them to use assistive devices and modify their environment to avoid fatigue. Explore strategies to manage stress and avoid undue stress. Often patients are anxious and worry about how long their remission will last or when the disease will progress. MS affects the entire family because of the unpredictability and uncertainty of the course of the disease. Chronic fatigue may also prevent prevent the patient from participating in family and community activities. We want to assess coping strategies of the family members or other caregivers and help them identify support systems that can assist them as they live with the patient with MS. Because personality changes are not unusual, teach the family or significant others strategies to enable them to cope with these changes. For example, the family may develop a nonverbal signal to alert the patient to potentially inappropriate behaviors. This action avoids embarrassment for the patient. Sexual dysfunction may occur as a result of fatigue, nerve involvement, and/or physiological reasons. Therefore, some patients may benefit from counseling. If able, answer the patient's questions or refer the patient to a counselor or urologist when they experience issues with the field of sexuality, intimacy, and disability. Prostaglandin 5 inhibitors, including Sinfadil, can be used to help men with erectile dysfunction. Penile prosthesis are also used for men. The Eros clitoral therapy device is a U.S. Food and Drug Administration approved therapy for women with impaired sexual response. And we could refer the patient and family members or significant others to local chapters of the National Multiple Sclerosis Society and other resources that can help with meal delivery services or transportation services for the disabled. The next exemplar in the book was spinal cord injuries. Spinal cord injuries can occur at any level of the spine. Potential survivors of an acute spinal cord injury experience injury below the third cervical level. Spinal cord injuries is the leading cause of paralysis and results in a physical disability. Many health issues experienced by patients who live with spinal cord injuries are related to impaired mobility. For a pathophysiology review, spinal cord injuries can be classified as complete or incomplete. A complete spinal cord injury is one in which the spinal cord has been damaged in a way that eliminates all innervations below the level of the injury. Injuries that allow some function or movement below the level of injury are described as an incomplete SCI. Incomplete SCIs are more common than complete injuries. Loss or decreased mobility, sensory perception, and bowel and bladder control often result from an SCI. Mechanisms of the injury. When enough force is applied to the spinal cord, the resulting damage causes many neurologic deficits. Sources of force include direct injury to the vertebral column, such as a fracture, dislocation, and subluxation, which is a partial dislocation, or a penetrating injury from violence, such as a gunshot or knife wound. Although in some cases the cord itself may remain intact, at other times it undergoes a destructive process caused by a contusion or a bruise, compression, laceration, or transaction, which is severing of the cord, either complete or incomplete. The cause of an SCI can be divided into primary and secondary mechanisms of injury. 5 primary mechanisms can result in an SCI. This would be hyperflexion, a sudden and forceful acceleration or movement of the head forward, causing extreme flexion of the neck. This is often the result of a head-on motor vehicle collision or a driving accident. Flexion injuries to the lower thoracic and lumbar spine may occur when the trunk is suddenly flexed on itself, such as occurs in a fall on the buttocks. Hyperextension occurs most often in vehicle collisions in which the vehicle is struck from behind or during falls when the patient's chin is struck. The head is suddenly accelerated and then decelerated. This stretches or tears the anterior longitudinal ligament, fractures or subluxates the vertebral, and perhaps ruptures an intervertebral disc. As with flexion injuries, the spinal cord may easily be damaged. Axial loading or vertical compression injuries result from diving accidents, falls on the buttocks, or a jump in which a person lands on their feet can cause many of the injuries attributed to axial loading or vertical compressions. A blow to the top of the head can also cause a vertebrae to shatter. Pieces of bone enter the spinal canal and damage the cord. Excessive rotation results from injuries that are caused by turning the head beyond the normal range, and then penetrating trauma is classified by the speed of the object, like a knife or a bullet, causing the injury. Low speed or low impact injuries cause damage directly to the site or local damage to the spine and the spinal cord and nerves. In contrast, high speed injuries that occur from like a gunshot wound or a GSW cause both direct and indirect damage. Secondary injury worsens the primary injury and may result in death. Secondary injuries include hemorrhage, ischemia, which is a lack of oxygen, typically from reduced absent blood flow, hypovolemia, which is a decreased circulating blood volume, impaired tissue perfusion from neurogenic shock, which is a medical emergency, and local edema. Hemorrhage into the spinal cord may manifest with contusion or petechial leaking into the central gray matter and later into the white matter. Systemic hemorrhage can result in shock and decreased perfusion of the spinal cord. Edema occurs with both primary and secondary injuries contributing to capillary compression and cord ischemia, and neurogenic shock, loss of blood vessel tone, or dilation after severe cord injury may result in hypoperfusion. Patients who have SCI have a decreased life expectancy owing to complications of immobility or, most often, some type of infection. The major cause of death are pneumonia and septicemia. Trauma is the leading cause of spinal cord injuries, with more than a third resulting from vehicle crashes. Other leading causes for falls are acts of violence, usually gunshot wounds, and sports or recreation-related accidents. Spinal cord injuries from falls are particularly likely among older adults. Spinal cord damage in older adults can also result from non-traumatic vertebral fracture and diseases such as tumors or degenerative conditions. About 18,000 new spinal cord injuries occur every year in the United States. However, an estimated 300,000 or more individuals live with a spinal cord injury as a physical disability. Almost 80% of all spinal cord injuries occur in young males, with the majority being white. Cervical cord injuries are more common than thoracic or lumbar cord injuries. The most common neurologic level of injury is C5. For patients with paraplegia, T12 and L1 are the most common levels. The average age of patients who have spinal cord injuries is 43 years. Spinal cord injury is more prevalent among veterans who served in combat in Iraq and Afghanistan when compared to those who served in previous wars. Most of the spinal cord injuries resulted from blunt trauma caused by blast injuries. Be aware that veterans who experienced a spinal cord injury from blast injuries typically have other polytraumatic injuries, including traumatic brain injuries and amputation of one or more limbs. These additional injuries take priority over attending to the problem related to the spinal cord injury and present a major challenge in managing care. Because trauma is the leading cause of spinal cord injuries, we need to teach patients to avoid taking risks, if possible, by ensuring adequate protective measures. An example, padding and helmets for sports and recreational activities. Remember to remind them to wear seatbelts at all times when driving and to avoid impaired driving caused by alcohol, marijuana, and other substances. Instruct them on the dangers of diving into shallow pools or other water when the depth is unknown. Water should be at least 9 feet deep before diving is attempted. When obtaining a history from a patient with an acute spinal cord injury, gather as much data as possible once the patient is stabilized about how the accident occurred and the probable mechanism of injury. Important data includes the location and position of the patient immediately after the injury, symptoms that occurred immediately with the injury, changes that have occurred subsequently, type of immobilization devices used and whether any problems occurred during stabilization and transport to the hospital, treatment given at the scene of injury and or in the emergency room, such as medications and IV fluids, medication history and medical history, including osteoporosis or arthritis of the spine, congenital deformities, cancer, and previous injury or surgery to the neck or back, history of any respiratory problems, especially if the patient has experienced a cervical spinal cord injury. The initial assessment is a priority focus for the patient's airway, breathing, and circulation. After an airway is established, we need to assess the patient's breathing pattern. The patient with a cervical spinal cord injury is at a high risk for respiratory compromise because cervical spinal nerves, C3 through 5, innervate the phrenic nerve controlling the diaphragm. We have to evaluate the pulse, blood pressure, and peripheral perfusion, such as pulse strength and capillary refill. Multiple injuries may contribute to circulatory compromise from hemorrhagic hypovolemic shock. We need to assess for indications of hemorrhage. All symptoms of circulatory compromise or hypovolemic shock must be treated aggressively to preserve tissue perfusion of the spinal cord. We use a Glasgow-Coma scale or other agency-approved assessment tools to assess the patient's level of consciousness. Cognitive impairment as a result of an associated traumatic brain injury or substance use disorder can occur in patients with traumatic spinal cord injuries. Spinal shock, also called spinal shock syndrome, occurs immediately as the cord responds to the injury. The patient has complete but temporary loss of motor, sensory reflex, and autonomic function that often lasts less than 48 hours, but may continue for several weeks. Common symptoms include decreased heart rate, decreased blood pressure, and pale ash gray or flushed skin. Spinal shock is not the same as neurogenic shock. We want to perform a detailed assessment on the patient's mobility and sensory perception status to determine the level of injury and establish baseline data for future comparison. The level of injury is the lowest neurologic segment with intact or normal motor and sensory function. Tetraplegia, also called quadriplegia or paralysis, and quadriparesis, which is weakness, involves all four extremities, as seen with cervical cord and upper thoracic injury. Paraplegia, paralysis, and paraphlesis, weakness, involves only the lower extremities, as seen in lower thoracic and lumbosacral injuries or lesions. The neurologic level defined by the American Spinal Injury Association refers to the highest neurologic level of normal function and is not the same as the anatomic level of injury. The neurologic level is determined by evaluating the zones of sensory and motor function known as the dermatomes, areas of the skin in which sensory nerves derive from a single spine nerve root, and myotomes, the set of muscles innervated by the spinal nerve. The patient may report a complete sensory loss or hypothesia, which is decreased sensory perception, or hyperasia, which is increased sensory perception. The primary healthcare provider may also test deep tendon reflexes, including the biceps, triceps, patellar, and ankle. It is not unusual for the reflexes, as well as all mobility or sensory perception, to be absent immediately after an injury because of spinal shock. After spinal shock is resolved, the reflexes may return. Cardiovascular dysfunction results from disruption of sympathetic fibers of the autonomic nervous system, especially if the injury is above the 6th thoracic vertebrae. Bradycardia, hypotension, and hypothermia occur because of loss of sympathetic input. These changes may lead to cardiac dysrhythmias. A systolic blood pressure below 90 millimeters of mercury requires treatment because lack of perfusion to the spinal cord could worsen the patient's condition. A patient with a cervical spinal cord injury is at risk for breathing problems resulting from an interruption of spinal innervation to the respiratory muscles. In collaboration with the respiratory therapist, if available, perform a complete respiratory assessment, including pulse oximetry for arterial oxygen saturation at least every 8 to 12 hours, more often if in the acute stages. An oxygen saturation of 92% or less and adventitious breath sounds may indicate a complication such as atelectasis or pneumonia. Autonomic dysreflexia, sometimes referred to as autonomic hyperflexia, is a potentially life-threatening condition in which noxious visceral or cutaneous stimuli causes sudden, massive, uninhibited reflex sympathetic discharge in patients with high levels of spinal cord injury. The signs and symptoms of autonomic dysreflexia are severely elevated blood pressure that can cause a hemorrhagic stroke. The causes of autonomic dysreflexia are typically GI or GU and vascular stimulation. So specific risk factors are bladder distension, urinary tract infection, epididymitis or scrotal compression, bowel distension or impaction from constipation or irritation of hemorrhoids. Pain can also cause it, circumferential constriction of the thorax, abdomen, or an extremity like with tight clothing, contact with hard or sharp objects, and temperature fluctuations can also cause autonomic dysreflexia. Patients with altered sensory perception are at great risk for these complications. When we're assessing the patient's abdomen for symptoms of internal bleeding, such as abdominal distension, pain, or paralytic ileus, Hemorrhage may result from the trauma, or it may occur later from a stress ulcer or the administration of steroids. We want to monitor the abdominal pain and changes in bowel sounds. Paralytic ileus may develop within 72 hours of a hospital admission. During this period of spinal shock, peristalsis decreases, leading to a loss of bowel sounds and to gastric distension. This disruption of the autonomic nervous system may lead to a hypotonic bowel. After the first few days, when edema subsides, the spinal reflexes that innervate the bowel and bladder usually begin to establish function, depending on the level of the injury. Patients with a cervical or higher thoracic spinal cord injury have upper motor neuron damage that spares lower spinal reflexes, causing a spastic bowel and bladder. Patients with lower thoracic and lumbar sacral injuries usually have damage to the lower spinal nerves and therefore have a flaccid bowel and bladder. Patients with complete SCI are at a higher risk for complications that result from prolonged impaired mobility, including pressure injuries and venous thromboembolisms. Assess skin integrity with each turn or reposition. Monitor for signs of venous thromboembolism with vital signs, including lower extremity DVTs. More detailed information on prevention and management of these complications can be found elsewhere in the text. Bones can become osteopenic and osteoporotic without weight-bearing exercising, placing the long-term spinal cord injury patient at risk for fractures. Another complication of prolonged immobility is heterotropic ossification, or bony overgrowth, often into the muscles. We want to assess for swelling, redness, hyperpigmentation, warmth, and decreased range of motion of the involved extremity. The hip is the most common place for the heterotropic ossification. Changes in the bony structure are not visible until several weeks after the initial symptoms appear. As far as psychosocial goes, patients experiencing a spinal cord injury may have significant behavioral and emotional reactions as a result of changes in functional ability, body image, role performance, and self-concept. Many of these patients are young men who may feel guilty for engaging in high-risk behaviors such as diving into a shallow pool or racing a vehicle that caused the injury. Some patients with spinal cord injuries are war veterans. Although patients assess patients for their reaction to the injury and provide opportunities to listen to their concerns, be realistic about their abilities and projected function, but also offer hope and encouragement. Aggressive rehabilitation can help most patients live productive and independent lives. The primary healthcare provider may request basic laboratory studies for the patient with a spinal cord injury to establish baseline data. Spine CT and MRI are performed to determine the degree and extent of damage to the spinal cord and detect the presence of blood and bone within the spinal column. In addition, patients may have a series of x-rays of the spine to identify vertebral fractures, subluxations, or dislocations. Potential for respiratory distress or failure due to aspiration, decreased diaphragmatic innervation, and/or decreased mobility. Potential for cardiovascular instability, an example, shock and autonomic dysreflexia due to loss of interruption of sympathetic innervation or hemorrhage. Potential for secondary spinal cord injury due to hypoperfusion, edema, or delayed spinal column stabilization. And decreased mobility and sensor perception due to spinal cord damage and edema are all different priority hypotheses that we can analyze for the spinal cord injury patient. Some interventions that we'll look at for patients with spinal cord injuries are airway management as the priority for patients with cervical spinal cord injuries. Patients with injuries at or above T6 are especially at risk for respiratory distress and pulmonary embolus during the first 5 days after injury. These complications are caused by impaired functioning of the intercostal muscles and disruption in the innervation of the diaphragm. Depending on the level of injury, intubation or a tracheotomy with mechanical ventilation may be needed. Respiratory secretions are managed with manually assisted coughing, pulmonary hygiene, and suctioning. We have to implement strategies to help ventilator-associated pneumonia when the patient needs continuous mechanical ventilation. So we'll have to make sure that they're not getting sick because of our treatment. Encourage the non-mechanically ventilated patient to use an incentive spirometer. The nurse and respiratory therapist should perform a respiratory assessment at least every 8 hours to determine the effectiveness of these strategies. In some cases, it may be necessary to perform oral and nasal suctioning if the patient cannot effectively clear their own airway of secretions. We want to teach the patient about who is a tetraplegic to coordinate cough effort with an assist. The nurse or other assistant places both hands on the upper abdomen over the diaphragm and below the ribs. Hands are placed one over the other with fingers interlocking and away from the skin. If the patient is obese, an alternate hand placement is one hand on either side of the rib cage. Have the patient take a breath and cough during expiration. The assistant locks the elbows and pushes inward and upward as the patient coughs. This technique is sometimes called the assisted coughing, quad coughing, or cough assist. We want to repeat the coordinated effort with rest period as needed until the airway is cleared. For cardiovascular instability, the patient is expected to not develop neurogenic or hypovolemic shock due to hemorrhage and is expected to be free of episodes of autonomic dysreflexia. If any of these potentially life-threatening complications occur, the patient is expected to receive prompt interventions with positive outcomes. We want to maintain adequate hydration through IV therapy and oral fluids as appropriate, depending on the patient's overall condition. Carefully observe for manifestations of neurogenic shock, which can occur 24 hours after injury, most commonly in patients with injuries above T6. The potentially life-threatening problem results from disruption in the communication pathways between the upper motor neurons and the lower motor neurons. Dextran, a plasma expander, may be used to increase capillary blood flow within the spinal cord and prevent or treat hypotension. Atropine sulfate is used to treat bradycardia if the pulse rate falls below 50 to 60 beats per minute. Hypotension, if severe, is treated with continuous IV sympathetic agents such as phenylephrine, dopamine, or other vasoactive agents. In addition to observing the patient for shock or hypotension, we want to monitor the patient who has a high level of spinal cord injury for the additional risk of the autonomic dysreflexia. AD is a neurologic emergency and must be promptly treated to prevent a hypertensive stroke. We want to be sure to reduce potential causes for this complication by preventing bowel and bladder distension, managing pain and room temperature, and monitoring for infection. If the patient has a fractured vertebrae, the primary concern of the healthcare team is to reduce and immobilize the fracture to prevent further damage to the spinal cord from bone fragments. Non-surgical techniques include external fixation or orthotic devices, but surgery is often needed to better stabilize the spine and prevent further spinal cord damage. Typical surgical procedures include spinal fusions to manage cervical injuries. Metal wiring is used to secure bone chips taken from the patient's hip or other source of bone grafting, such as donor bone tissue. After surgical spinal fusion, we want to assess the patient's neurologic status and vital signs at least every hour for the first 4 to 6 hours, and then if the patient's stable, every 4 hours. We want to assess for complications of surgery, including worsening of the motor or sensory function at or above the site of the surgery, and document your assessments carefully and in detail. Failure to do so may prevent other staff members from quickly recognizing deterioration in the neurologic status. The patient may be placed in a fixed skeletal traction to maintain vertebral alignment and facilitate bone healing and prevent further injury, often after surgical stabilization. The most commonly used device for immobilization of the cervical spine is a halo fixator device, also called a halo crown, which can be worn for 6 to 12 weeks. This static device is affixed by 4 pins or screws into the outer aspect of the skull and is connected to a vest or jacket. For patients not having surgery, the addition of traction helps reduce the fracture. For thoracic and lumbar fusions, metal or steel rods, called Harrington rods, are used to keep the bone ends in alignment after fracture reduction. After surgery, the patient usually wears a molded plastic support, cervical or thoracic, lumbar, or both, to keep the injured and operated areas immobilized during recovery. Postoperative care is similar Because SCI is a physical trauma, the patient is started on a proton pump inhibitor such as Protonix to help prevent the development of stress ulcers. This drug may be administered IV or orally. Oral dose may be taken with or without food. An anticoagulant may be given as part of the VTE prevention protocol. Bulk-forming laxatives or stool softeners are given to prevent constipation. Other drugs to prevent or treat complications of immobility may be used later during the rehabilitation phase. For example, we might use Celebrex prescribed to prevent and treat heterotropic ossification. However, we want to recall that the adverse effects of the drug include increased risk for myocardial infarction and stroke. Calcium and biphosphonates may prevent osteoporosis that results from lack of weight-bearing or resistance activity. Osteoporosis can cause fractures in later years, so early and continued exercise may help decrease the incidence of these complications. Centrally acting skeletal muscle relaxants may help control muscle spasticity. Intrathecal baclofen therapy may be prescribed to treat muscle spasms without incurring the drowsiness and sedation often seen with the oral medications. This drug is administered through a programmable implantable infusion pump and intrathecal catheter directly into the cerebral spinal fluid. The pump is surgically placed in a subcutaneous pouch in the lower abdomen. We want to monitor for the infusion pump and common adverse effects, which include sedation, fatigue, headache, hypotension, and changes in the mental state. Seizures and hallucinations may occur if the intrathecal baclofen pump is suddenly withdrawn. Patients with a spinal cord injury are especially at risk for pressure injuries due to altered sensation perception of pressure areas of the skin below the level of the injury. They are also at risk for venous thrombosis, contractures, orthostatic hypotension, especially in patients with a high spinal cord injury, and fractures related to osteoporosis due to impaired mobility. Frequent and therapeutic positioning not only helps prevent complications, but also provides alignment to further prevent SCI irritability. Reposition the patient every 1 to 2 hours. We want to assess the condition of the patient's skin, especially over pressure points, with each turn of positioning. Turning may be performed manually, or the patient may be placed in an automatic rotating bed. Reduce pressure on any reddened area and monitor it with the next turn. When sitting in a chair, patients are repositioned or taught to reposition themselves more often than every hour. Paraplegic patients usually perform frequent wheelchair push-ups to relieve skin pressure. We use a pressure-reducing device and wheelchair or chair pads to help prevent skin breakdown. We want to prevent pressure injuries by using best practices. The prevention of blood clots includes the interventions of intermittent pneumatic compression stockings and low molecular weight heparin. Patients with cervical spinal cord injuries especially are at high risk for orthostatic or postural hypotension, but anyone who is immobilized may have this problem. If the patient changes from a lying position to a sitting or standing position too quickly, the patient may experience hypotension, which could result in dizziness and falls. Because of interrupted sympathetic innervation caused by the spinal cord injury, the blood vessels do not constrict quickly enough to push the blood up into the brain. The resulting vasodilation causes dizziness or lightheadedness and possible falls and syncopes or blackouts. In collaboration with the rehabilitation team, we want to teach or reinforce teaching about bed mobility skills and bed-to-chair transfers. Patients with paraplegia are usually able to transfer from bed to chair or a wheelchair with minimal to no assist unless balance is a problem. We want to see this in patients with higher thoracic injuries. Techniques to improve balance are usually taught by occupational or physical therapists. Tetraplegic patients may learn how to transfer using a slider, also called a sliding board. This simple board-like device allows the patient to move from the bed to the chair or vice versa by creating a bridge. When using the slider, we want to remind patients to lift their buttocks while moving incrementally and slow across the board. Patients with severe muscle spasticity may have challenges when learning transfer skills, and contractures are common. Contractures may be prevented or minimized with splints and range of motion activities. All patients with a spinal cord injury require bowel and bladder training. including adequate fluids, 1.5 to 2 liters each day, and stool softeners to prevent constipation from immobility and the injury itself. Those with upper motor neuron lesions, usually cervical and high thoracic injuries, have spastic bowel and bladder function with an intact spinal reflex for elimination. However, voiding patterns may be uncontrolled and require long-term indwelling or external catheters, leading to frequent urinary tract infections. An implanted intraurethral device may be an option for some female spinal cord injury patients. Rectal suppositories are often successful to promote regular bowel elimination. The patient with a lower motor neuron lesion has a flaccid bowel and bladder. Intermittent urinary catheterizations, manual pressure over the bladder area, and bowel disimpaction on a regular basis help to establish a routine. In patients with established or long-term spinal cord injuries, we have to assess the baseline abilities and encourage their participation in self-care and management. We want to encourage family members' participation in care and support their efforts to keep the patient engaged in family life. Rehabilitation after an acute SCI begins in the acute or critical care unit when patients are hemodynamically stable. They are usually transferred from the acute care setting to a rehabilitation setting where they learn about self-care, mobility skills, and bladder and bowel retraining. The primary purpose of rehabilitation with an SCI is to enable patients to function independently in their community. However, physical barriers still exist in some communities that prevent the patient in a wheelchair from finding a part to place, using sidewalks and attending activities or accessing resources. One new but promising therapy in rehabilitation is functional electrical stimulation. FES uses small electrical pulses to paralyze muscles to restore or improve their function. It is commonly used for exercise, but it is also used to assist with breathing, grasping, transferring, standing, and walking. The occupational therapist instructs the patient in the correct use of all the adaptive equipment and therapies. Wearable robotic exoskeletons have also shown promise in improving quality of life in patients with spinal cord injury. These battery-powered devices typically fit over the hips and lower extremities, allowing the patient to walk at home and in the community. A full-time caregiver or personal assistant is sometimes required when the patient has tetraplegia, returns home from rehabilitation. The caregiver may be a family member or a nursing assistant employed to help provide care and companionship. The patient who is paraplegic is usually able to provide self-care without assistance after an appropriate rehabilitation program. Abu Baker et al. Conducted a study to determine which specific factors contribute to high self-care ability and quality of life for patients with SCI living in the community. In addition to self-care ability, sexual function after SCI also depends on the level and extent of injury. Incomplete lesions allow some control over sensory perception and mobility. Complete lesions disconnect the message from the brain to the rest of the body and vice versa. However, men with injuries above T6 are often able to have erections by stimulating reflex activity. For example, stroking the penis will cause an erection. Ejaculation is less predictable and may be mixed with urine. However, urine is sterile, so the patient's partner will not get an infection. To prevent autonomic dysreflexia, prophylactic administration of a vasodilator may be needed before intercourse. Women with spinal cord injuries have a different challenge because there are indwelling urinary catheters more commonly than men. Some women do become pregnant and have full-term children. For others, ovulation stops in response to the injury. In this case, alternative methods for pregnancy, such as in vitro fertilization, may be the option. Some women also report vaginal dryness. It's recommended to use a water-soluble lubricant for both partners to promote comfort during intercourse. Unfortunately, some patients living with SCIs living in the community are periodically admitted to the acute care or long-term care setting for complications of immobility, such as pressure injuries or fractures resulting from osteoporosis. Pressure injuries contribute to local or systemic infections, including osteomyelitis and septicemia. We want to refer the patient and their family to local, state, or province and national organizations for more information and support for patients with SCI. These organizations include the United Spinal Association or the United States and Spinal Cord Injury of Canada. Many excellent consumer-oriented books, journals, and DVDs are also available. Support groups may be helpful for the patient and family to adjust to the changed lifestyle and provide solutions to commonly encountered problems. We want to evaluate the care of the patient with the SCI based on the identified priority patient problems. The expected outcomes are that the patient exhibits no deterioration in neurologic status. They maintain a patent airway, a physiologic breathing pattern, and adequate ventilation. Does not experience a cardiovascular event such as hemorrhagic shock, hemorrhage, autonomic dysreflexia, and receives prompt treatment if this event occurs. Does not have secondary complications such as a blood clot or heterotropic ossification. Is free from complications of decreased mobility and performs mobility skills and basic ADLs as independently as possible with or without the use of assistive adaptive devices. The next exemplar we're going to cover is over lower back pain, also called the lumbosacral back pain. Back pain affects most adults at the same time of their life. It can be recurrent, and subsequent episodes tend to increase in severity. The lumbosacral or lower back and cervical vertebrae are the most commonly affected because these are the areas where the vertebral column is the most flexible. Acute back pain is usually self-limiting and lasts less than 12 weeks. If the pain continues past 12 weeks or 3 months or more, the patient is considered to have chronic back pain. Lower back pain occurs along the lumbosacral area of the vertebral column. Acute pain is caused by a muscle strain or spasm, ligament sprain, and disc degeneration or osteoarthritis, herniation of the center of the disc, and nucleus pulposus. A herniated nucleus pulposus in the lumbosacral area can press on the adjacent nerve of the spine, usually the sciatic nerve, causing burning or stabbing pain down the leg or foot, which in some cases can be very severe. Herniated discs often occur most often between the fourth and the fifth lumbar spine, but may occur at other levels. The specific area of symptoms depends on the level of herniation. In addition to acute or persistent pain, there may also be muscle spasms and numbness and tingling or paresthesias in the affected leg because spinal nerve have been involved. Back pain may also be caused by spinal stenosis, which is the narrowing of the spinal canal, nerve root canals, or intervertebral foramina, typically seen in people older than 50 years old. This narrowing may be caused by infection, trauma, herniated disc, arthritis, and disc degeneration. Most adults older than 50 years have some degree of degenerative disc disease, although they may not be symptomatic. Low back pain is most prevalent during the third or sixth decade of life, but can occur at any time. Women have a higher incidence of lower back pain compared to men. Acute back pain usually results from injury or trauma, such as a fall or a vehicle crash, or when lifting a heavy object. The mechanism of injury includes repetitive flexion and or extension and hyperflexion or hyperextension, with or without rotation. Obesity places increased stress on the vertebral column and back muscles, contributing to the risk for injury. Smoking has been linked to degenerative disc disease, possibly caused by constriction of the blood vessels that supply the spine. Congenital spinal conditions such as scoliosis, an abnormal lateral curvature of the spine, could also lead to lower back pain at any age. Many of the problems related to back pain can be prevented by recognizing the factors that contributed to tissue injury and taking appropriate preventative measures to prevent the pain. For example, proper posture and exercise can significantly decrease the risk of lower back pain. The U.S. Occupational Safety and Health Administration, or OSHA, has mandated that all industries develop and implement plans to decrease musculoskeletal injuries among their workers. One way to meet this requirement is to develop an ergonomic plan for the workplace. Ergonomics is an applied science in which the workplace is designed to increase worker comfort, thus reducing injury, while increasing efficiency and productivity. An example is a ceiling lift designed to help nurse assistant patients to get out of bed. A variety of equipment can be used to decrease injury relating to movement patients. Professional guidelines and legislative rules promote safe patient handling and mobility for healthcare workers. The patient's primary concern is continuous pain. Some patients have so much pain that they walk in a stiff, flexed posture, or they may be unable to bend at all. They may walk with a limp, indicating possible sciatic nerve impairment. Walking on the heels or toes often causes severe pain in the affected leg, the back, or both. We want to conduct a complete pain assessment. We want to record the patient's current pain score and the worst and best scores since the pain began. Ask about precipitating or relieving factors such as symptoms at night or during rest. Determine whether a recent injury to the back has occurred. It is not unusual for the patient to say, "I just moved to do something and felt my back go out." Inspect the patient's back for vertebral alignment and tenderness. Examine the surrounding anatomy and lower extremities for secondary injuries. Patients will often describe pain as stabbing and continuous in the muscle closest to the affected disc. They often describe a sharp burning posterior thigh or a calf pain that may radiate to the ankle or toes along the path of one or more spinal nerves. Pain usually does not extend to the entire length of the limb. Patients may also report the same type of pain in the middle of one buttock or hip. The pain is often aggravated by sneezing, coughing, or straining. Driving a vehicle can be particularly painful. Ask whether paresthesia, or the tingling sensation and numbness, is present in the involved leg. Both extremities may be checked for sensory perception by using a cotton ball and a paperclip for comparison of light and dull and sharp touch. The patient may feel sensation in both legs, but may experience a stronger sensation on the unaffected side. Ask about urinary and fecal continence and difficulty with urination or having new onset constipation. If the sciatic nerve is compressed, severe pain usually occurs in the patient's leg if it's held straight and lifted upward. The foot, ankle, and leg weakness that may accompany the lower back pain. To complete the neurologic assessment, evaluate the patient's muscle tone and strength. Muscle in the extremities or lower back can atrophy as a result of severe persistent back pain. The patient has difficulty with movement, and certain movements create more pain than others. Ask the patient whether they have frequent feelings of sadness, and also consider suicide. For many patients, persistent pain can cause depression and suicidal ideation. Imaging studies for patients who report mild nonspecific back pain may not be done, depending on the nature of the pain. Patients with severe progressive motor or sensory perception deficits, or who are thought to have other underlying conditions, an example, cancer or infection, require complete diagnostic assessments. To determine the exact cause of the pain, a number of diagnostic tests may be used, including plain x-rays to show the general arthritis changes and bony alignment, CT scan, which shows the spinal bones, the nerves, the discs, and the ligaments. MRI, which provides imaging of the spinal tissue, bones, spinal cord, nerves, ligaments, musculoskeleture, and discs. Bone scans, which show bone changes after injection of radioactive tracers, which attach to areas of increased bone production to show increased vascularity associated with tumors or infection, and then electrodiagnostic testing such as the EMG or electromyography, and nerve conduction studies to distinguish motor neuron disease from peripheral neuropathy or radiculotherapy, which is a spinal nerve root involvement. These tests are especially useful in chronic diseases of the spinal cord or associated nerves. Management of patients with lower back pain varies with the severity and chronicity of the problem. In acute pain, it is not treated or managed effectively. Persistent pain may occur. Most patients with acute lower back pain experience spontaneous resolution of pain and other symptoms in less than 3 months. Some patients need only a brief treatment regimen of an at-home exercise or physical therapy to manage pain. In general, they return to work, if safe, is beneficial for recovery and well-being. Some patients have continuous or intermittent chronic pain that must be managed for an extended period. Referral to an interprofessional team that specializes in pain or back pain can provide expert long-term management. For patients with acute nonspecific lower back pain, non-pharmacologic agents are often the first-line treatment, although a recent clinical guideline published by the North American Spine Society found insufficient evidence to support many of the most common recommended treatments. A short period of back rest and heat or ice may be prescribed. Heat has been shown to offer some short-term benefits. Physical therapy can help strengthen surrounding muscles, and the therapist can educate the patient on preventing further injury. The North American Spinal Society work group could not find conclusive evidence to endorse ultrasound treatments transcutaneous electrical nerve stimulators or TENS units, laser therapy, traction, dry needling or acupuncture, bracing, or massage therapy, although individual patients may get relief from any of these modalities. The patient should begin stretching exercises and resume normal daily activities as soon as possible, including returning to work if safe to do so. Aerobic exercises have good evidence to support its use when patients are able. Most patients also find that they need to change positions frequently. Prolonged standing, sitting, or lying down increases back pain. If the patient must stand for a long time for work or other reasons, shoe insoles and special floor pads may be helpful to decrease pain. The Williams position is typically more comfortable and therapeutic for patients with acute lower back pain from a bulging or herniated disc. In this position, the patient lies in a semi-Fowler's position with a pillow under the knees to help them flex or sit in a reclined chair. This position relaxes the muscles of the lower back and relieves pressure of the spinal nerve root. Many patients worry that their lower back pain will not resolve, and in some cases the pain can convert to a chronic condition. Other patients will have no further reoccurrences. The nurse should provide honest information, reassure the patient that another episode might never occur. It's recommended that the psychosocial and conclusive evidence that workplace factors, pain severity, prior episodes of back pain, and functional impairment be considered when assessing the risk for chronicity. Patients with chronic lower back pain are also initially managed with non-pharmacologic interventions. In addition to the measures discussed earlier, patients may benefit from complementary and integrative therapies such as stress reduction, mindfulness, progressive muscle relaxation, and yoga. Pain catastrophizing has been shown to cause increased distress. Cognitive behavioral therapy, in addition to physical therapy, has strong evidence to support its use in patients with pain that continues beyond 12 years. If medications are needed, non-selective NSAIDs such as aspirin, ibuprofen, and naproxen are helpful, although antidepressants and antiepileptics such as Neurontin are often prescribed. On the other hand, patients with chronic pain may be depressed. In that case, antidepressants may be appropriate. They did say that the NAS also found insufficient evidence for treatment with steroids, either oral or IV. Opioids have a very limited role in the treatment of back pain. They are used sparingly and for a short period of time in the acute stage. Topical capsaicin provides good relief for pain for a short-term basis. There is no evidence that lidocaine patches provide significant relief. Zinotide is a potent analgesic sometimes used for patients who have severe persistent pain. Muscle spasms can occur, for which the provider may prescribe central acting muscle relaxants. Commonly used will be diazepam, cyclobenzaprine, methotrexate, and tizanidine. A physical therapist works with the patient to develop an individualized exercise program. The type of exercise prescribed depends on the location and nature of the injury and the type of pain. McKenzie exercises are often utilized to help reposition the misaligned vertebral discs, strengthening surrounding muscle, and then teaching the patient how to manage back or neck pain themselves. These exercises include extended and flexion positions to centralize the back pain. The patient does not begin exercises until acute pain is reduced by other means. Water therapy combined with exercise is helpful for some patients with chronic pain. The water also provides muscle resistance during exercise to prevent atrophy. Weight reduction may help reduce persistent lower back pain by decreasing the strain on the vertebra and the vertebral complex caused by excessive weight. If the patient's weight exceeds the ideal by more than 10%, caloric restrictions is considered. Healthcare professionals must be sensitive when discussing weight reduction, however, and include behavioral approaches to weight loss and positive reinforcement as part of the plan. Surgery may need to be performed if conservative measures fail to relieve persistent back pain or if neurogenic deficits continue to progress. An orthopedic surgeon and/or a neurosurgeon performs these surgeries. Two general surgical methods are used depending on the severity and exact location of pain: minimally invasive surgeries and conventional open surgical procedures. Minimally invasive surgery is not done if the disc is pressing on the spinal cord or essential cord involvement. Preoperative care for the patient preparing for a lumbospinal surgery is similar to that with a patient going any surgery. We're going to teach the patient about postoperative expectations depending on the surgical method, including techniques to get in and out of bed, turning and moving in bed, immediately reporting any new sensationary perceptions such as numbness and tingling, or new motor impairment that may occur if the affected leg or in both legs. Home care activities and restrictions, if any. As part of the preoperative teaching, make sure the patient understands the type of procedure they're having and the postoperative care that will be needed. A recent randomized controlled trial found that the knowledge of patients about their surgical procedures was inadequate. There are no significant differences between the knowledge of patients who had routine preoperative education and the patients who had a specific preoperative education on their spinal surgical procedure. Newer surgical procedures allow many patients to have same-day surgery. Other patients are discharged to home within 23 to 48 hours after surgery. Therefore, we're teaching the family members or other caregivers how to assist the patient and what restrictions the patient must follow at home before surgery occurs. The minimally invasive surgeries using endoscopy or percutaneous instrumentation results in minimal muscle injury, decreased blood loss, and decreased postoperative pain. Therefore, the primary advantages to a minimally invasive procedure are a shortened hospital stay, less pain, and the possibility of an ambulatory care or same-day procedure. Spinal cord and nerve complications are also less likely. Several specific procedures are commonly performed. A microdiscectomy involves microscopic surgery directly through a 1-inch incision using an endoscope. This procedure allows easier identification of anatomic structures, improves precision in removing small fragments, and decreases tissue trauma and pain. A special cutting tool or laser probe is thread through the cannula for removal or destruction of the disc pieces that are compressing the nerve root. This process is called a percutaneous endoscopy discectomy. A newer procedure combines the peripheral endoscopy with laser thermodiscectomy to also shrink the herniated disc before removal. Inpatient hospitalization is not necessary for these procedures. Laser-assisted laparoscopic lumbar discectomy combines a laser with modified standard disc instruments inserted through the laparoscopic using an umbilical or belly button incision. This procedure may be used to treat herniated discs that are bulging but do not involve the vertebral canal. The primary risk of this surgery are infection and nerve root injury. The patient is usually discharged in 23 hours but may go home sooner. The newest addition to the microdiscectomies procedures is a robot-assisted spinal surgery. This procedure requires additional training and experience for the surgeon and is currently limited to the assistance with hardware placement. The most common open surgery procedures are discectomy, laminectomies, and/or spinal fusions. Artificial disc replacement may also be part of this type of surgery. These procedures involve a surgical incision to expose the anatomic landmarks for extensive muscle and soft tissue dissection. The location and length of the incision depends on the procedure and on the surgeon's preference and training. As the name implies, a discectomy is removal of a herniated disc. A laminectomy involves removal of part of the laminae and facet joints to obtain access to the disc space. A spinal fusion connects two or more vertebrae to stabilize the spine and release compression on nerves. In an interbody cage fusion surgery, a titanium mesh device is placed, implanted in the space where the discs were removed, and several screws ensure stabilization. When repeated laminectomies are performed or the spine is unstable, the surgeon may perform a spinal fusion with bone graft to stabilize the affected area. Chips of cadaver bone are ground and grafted between the vertebrae for support and to strengthen the back. Metal implants, usually titanium pins, screws, plates, or rods, may be required to ensure the fusion of the spine. The surgeon may give an intrathecal or an epidural dose of a long-acting morphine to decrease postoperative pain. Postoperative care depends on the surgical method and procedure that was performed. In the post-anesthesia care unit, or the PACU, vital signs and level of consciousness are monitored frequently, as for any surgery. Best practices for PACU nurses is that they're monitoring those vitals quite frequently and assessing the patient's airway. Patients who have minimally invasive surgery go home that same day or the day after surgery with one or more wound closure tapes over the small incision. Those having a microdiscectomy may also have a clear or gauze dressing over the bandage. Most patients notice less pain immediately after surgery, but mild oral analgesics are needed while nerve tissue heals for over the next few weeks to promote patient comfort. We want to teach the patient to follow the prescribed exercise program, which begins immediately after discharge. Patients should start walking routinely every day. Complications of a micro surgery are rare. Early postoperative nursing care focuses on preventing and assessing complications that might occur in the first 24 to 48 hours with the patient having a conventional open surgery. Major complications for open traditional lumbar spinal surgeries include nerve injuries, discitis, and dural tears. As for the patient undergoing surgery, we want to take those vital signs at least every 4 hours during the first 24 hours to assess for fever, hypotension, or severe pain. Perform a neurologic assessment every 4 hours. Of particular importance are movement strength and sensory perception of the lower extremities. Carefully check the patient's ability to avoid after catheter removal. Acute back pain and a flat position in the bed make it difficult to void, especially for men. An inability to void may indicate damage to the sacrospinal nerves, which control the detrusor muscles in the bladder. The patient with an open traditional discectomy, laminectomy, and/or traditional open spinal fusion typically get out of bed with assistance on the evening of the surgery, which may help with voiding. Correct turning of the patient in the bed who is receiving from open traditional lumbar spinal injury is especially important. Do not place an overhead trapeze on the bed to assist the patient with mobility skills. This apparatus can cause more back pain and damage the surgical area. We want to teach the patient to log roll every 2 hours from side to back and vice versa. In log rolling, the patient turns as a unit while the back is kept as straight as possible. A turning sheet may be used for obese patients. Either turning methods may require additional assistance depending on how much the patient can assist. Instruct the patient to keep their back straight while getting out of bed. The patient should sit in a straight back chair with the feet resting comfortably on the floor. As with all surgical patients, we want to prevent atelectasis and hypostatic pneumonia with deep breathing and incentive spirometer. When a lumbar spinal fusion is performed in addition to an open laminectomy, more care is taken with positioning. The nurse or the assistive personnel assist the log rolling with this patient every 2 hours while in bed. We want to remind the patient to avoid prolonged sitting or standing. Be sure to check with the surgeon or surgeon's prescription regarding whether to place the orthotic device or brace on the patient before or after getting the patient out of bed. The patient with back pain who does not undergo surgery is typically managed at home. If back surgery is performed, the patient is usually discharged to home with support from family or significant others. For older adults without a community support system, a short-term stay at a nursing home or transitional care unit may be needed. Collaborate with the case manager or discharge planner, patient and family to determine the most appropriate placement. Patients having any of the micro procedures or a lumbar inner body fusion may resume normal activities within a few days to up to 3 weeks after surgery, depending on the specific procedure and the condition of the patient. The patient may take a shower on the 3rd or 4th day after surgery. Teach the patient to leave the wound closure tapes in place for removal by the surgeon or until they fall off. Instruct the patient to contact their primary care provider immediately if clear drainage seeps from the incision. Clear drainage usually indicates a dural tear and that cerebrospinal fluid is leaking. After conventional open lumbar surgery, the patient may have activity restrictions and recommendations for the first 4 to 6 weeks, including limit daily stair climbing, restrict or limit driving, do not lift objects heavier than 5 pounds, restrict pushing and pulling activities such as dog walking, and avoiding bending or twisting at the waist, and take a daily walk. While the bone graft heals from an open spinal fusion, the patient may wear a back orthotics device for the 4 to 6 weeks or longer after surgery. We want to provide information about the importance of wearing the brace as instructed during the healing process, how to take it off and put it on while maintaining spinal alignment, and how to clean it. The duration of home-based recovery depends on the nature of the patient's job and the extent of type of surgery. Most patients return to work after 2 to 6 weeks. Some patients have more complex open spinal procedures and may not return for several months if their job are physically strenuous. The primary healthcare provider may want the patient to continue taking anti-inflammatory, or if muscle spasm is present, to take muscle relaxants. Remind the patient and family about the side effects of the drugs and what to do if they occur. In a few patients, back surgery is unsuccessful. The situation referred to as a failed back surgery syndrome is a complex combination of organic, psychological, and socioeconomic factors. Repeated surgical procedures often discouraged for these patients who must continue aggressive pain management after multiple operations. Nerve blocks, implanted spinal cord stimulators, and other modalities may be needed on a long-term basis to help with persistent pain. A newer alternative is lysis of the epidural adhesions, if present, though a minimal invasive technique. Spinal cord stimulation is an invasive technique that provides persistent pain relief by applying an electrical field over the spinal cord. A trial with a percutaneous spinal cord stimulator is conducted to determine whether permanent placement is appropriate. If the trial is successful, electrodes are surgically placed internally into the epidural space and connected to an external or implanted programmable generator. The patient is taught to program and adjust the device to maximize comfort. Spinal cord stimulation can be extremely effective in select patients, but it is reserved for intractable or unrelenting and continuous neuropathic pain syndromes that have been unresponsive to other treatments. Cervical neck pain most often results from bulging or herniation of the nucleus pulposus, or an HNP, in a cervical intervertebral disc. The disc tends to herniate laterally, where the annulus fibrosus is weakest and the posterior longitudinal ligament is thinned. The result of a cervical herniation of the nucleus pulposus is spinal nerve root compression, with motor and sensory manifestations and moderate to severe pain, typically in the neck, upper back, over the shoulders, and down the affected arm. The disc between the 5th and 6th cervical vertebrae, C5 and C6, is often most affected. If the disc does not herniate, nerve compression may be caused by osteophyte or bone spur formation from osteoarthritis. The osteophytes press on the intervertebral foramen, which results in a narrowing of the disc and pressure on the nerve root. As with sciatic nerve compression, the patient with a cervical nerve compression may have either continuous or intermittent chronic pain. When the disc herniates centrally, pressure on the spinal cord occurs and requires prompt surgery to prevent paresis or paralysis. Cervical pain, acute or persistent, can also occur from muscle strain, ligament sprain resulting from aging, poor posture, lifting, tumor, rheumatoid arthritis, osteoarthritis, or infection. The typical history of the patient includes a report of pain and numbness or tingling when moving the neck, which radiates to the shoulders and down the arm. The pain may interrupt sleep and may be accompanied by a headache or numbness and tingling down the affected arm. To determine the exact cause, plain x-rays and imaging studies may be used. Electromyography nerve conduction studies are used to help differentiate cervical radiculopathy, ulnar or radial neuropathy, carpal tunnel syndrome, or other peripheral nerve problems. Conservative treatment for acute neck pain is the same as described for the lower back pain, except prescribed exercises focus on the shoulders and the neck. The physical therapist teaches the patient the correct techniques for performing shoulder shrugs, shoulder squeezes, and seated rows. Some primary healthcare providers prescribe a soft collar to stabilize the neck, especially at night. Using the collar for longer than 10 days can lead to decreased muscle strength, though, and range of motion. For that reason, many providers do not recommend collars for cervical disc problems. Therapeutic manipulation, such as chiropractic interventions alone or in combination with other therapy, does not appear to cause harm for most patients, but does not consistently reduce pain or disability either. If conservative treatment isn't effective, surgery may be required, either minimally invasive surgery or conventional open surgery. A neurosurgeon usually performs the surgery because of the complexity of the nerves and the other structures in the area of the spine. For open procedures, and depending on the cause and the location of the disc herniation, either an anterior or a posterior surgical approach is used. One of the most commonly performed procedures in the anterior or lateral interbody cervical fusion. In this procedure, a titanium mesh device is implanted into the space where the cervical disc was removed, and several screws ensure stabilization. For clients who have multiple cervical disc herniations, a traditional anterior cervical discectomy and fusion with bone graft may be performed. The surgery is more complex and causes more postoperative complications. The patient having the traditional ACDF usually wears a soft collar for about 2 to 3 weeks after surgery. Some patients are candidates for minimally invasive surgeries, such as a percutaneous cervical discectomy through an endoscope with or without laser thermodiscectomy to shrink the herniated portion of the disc. The care for the patient is very similar to that of the patient with the lower back pain. Many patients have positive clinical outcomes after interbody fusion procedures, reducing the need for more complicated fusions and bone grafting. The patient has a small incision and is able to return to work in a few weeks. Complications for the procedure are not common. Patients may also benefit from the placement of an artificial disc, a surgical option that preserves movement of the vertebra. Artificial discs are approved by the FDA, although there is evidence of their safety. The long-term effects on patients' health is not yet established.